Welcome to this webinar on SART portals developed jointly by ASRM and SART. I am Sarah Ramaya, Curriculum Designer at ASRM, along with my colleagues Jessica Goldstein and Kelly Jefferson. Joining us are panelists Micah Hill, Ellie Reshef, Kathy Duty, and Ethan Wantman. Before we begin, please note, this webinar was developed by the Society for Assisted Reproductive Technology and the American Society for Reproductive Medicine as an educational resource and service to its members and other practicing clinicians. While this webinar reflects the views of the panelists, it is not intended to be the only approved standard of practice or to dictate an exclusive course of treatment. Members should always use their best judgment in determining a course of action and be guided by the needs of the individual patient, available resources, and institutional or clinical practice limitations. All attendees will be muted except the presenters. Time at the end of the presentation will be reserved for questions. Please type a question in the question chat window at any time. We will read as many selected questions as possible during the allotted question and answer time. A recording of this webinar will be archived on the ASRM website in the coming weeks. Please watch your email for notification. Let me introduce our moderator, Ethan Wantman. Mr. Wantman is a partner at Reshef Technologies and Chief Executive Officer at Registry Vision. Reshef is a custom software development firm which has built mission-critical digital product and service platforms for organizations, startups, and innovation labs across healthcare, retail, customer packaged goods, cosmetics, fashion, public sector, and nonprofit organizations. Registry Vision builds systems that store and analyze nutritional, mental, and physical health data. Mr. Wantman helps SART run the SART CORS registry system and services. Over to Ethan to introduce our panelists.
Thanks, Sarah. First, I'll introduce Dr. Hill. Dr. Hill is the IVF Director and the Staff Reproductive Endocrinologist at Walter Reed, and the Fellowship Director for the NIH REI Fellowship Program. He is board certified in both obstetrics and gynecology and reproductive endocrinology and infertility. He holds the title of Master Clinician at Walter Reed. He received his medical degree from Oklahoma State College of Osteopathic Medicine, his residency in obstetrics and gynecology at Tripler Army Medical Center, and fellowship at NIH. Dr. Hill is a lieutenant colonel in the U.S. Army and an associate professor of obstetrics and gynecology at USUHS. He serves as the interactive associate and chief for the editorial board of the Journal Fertility and Sterility, and serves as the chair of the Quality Assurance Committee for the Society of Assisted Reproductive Technology. Dr. Hill also serves in the practice committee for the American Society of Reproductive Medicine and the Society for Reproductive Endocrinology and Infertility.
Thank you, Ethan, for the introduction. I'll be talking today about the Quality Assurance Committee and how you can use portals to access your SART QA scorecard. So there is nothing to disclose. These are the members of the SART QA Committee. So in this talk today, we'll explain the purpose of the SART Quality Assurance Committee, summarize what the SART QA scorecard is and how it looks, describe how you can access and utilize the SART QA portal, measure the SART QA thresholds for citation of outlying clinics and explain how those thresholds are developed, and describe the process of how you can respond to SART QA citations. The purpose of the SART QA Committee is up here on the screen. This comes directly from our committee's charter within SART. Our role is to promote and advance the standards of SART ART practice within the United States, and we do this through two primary ways. One is by tracking twin and high-order multiple gestation rates to assure that IVF is being practiced in a safe manner. The second is to promote quality by tracking live birth rates to ensure that we are achieving the highest quality for our patients in SART member clinics. The purpose of SART the QA Committee is not to be punitive as we enforce these standards, but rather to work with clinics in a way that is collaborative, purposeful, constructive, and collegial in upholding SART quality membership standards. This is the process of the SART Quality Assurance Committee. Annually, the data is collected and validated by the Validation Committee. The SART QA Committee then receives the data and analyzes for national changes and trends in our primary metrics. The QA Committee analyzes the data to set where we will make those thresholds for citation. Typically, that is at the 5th percentile of nationally performing clinics, although we do reassess this each year to ensure that that threshold still has meaning. Once that threshold is established, all clinics will receive an email with their SART QA scorecard. So this email essentially informs you that you need to log in to the SART QA portal to view your scorecard. We do want the scorecard to be private between the QA committee and the clinic. So your email will not contain the information. It will tell you that you need to log into the QA portal, which we'll talk about in a minute, and how you can view your data. Once you do this and log in and look at your scorecard, no further action is required or expected. Clinics that fall below the 5th percentile on the primary metrics will receive a similar email, but when they log into the portal, it will say that they have a citation that they need to respond to. We ask that the clinic looks at their own data for that particular metric and replies to the committee within the portal. So action is required if you receive a citation. The QA committee will then review your response to the citation and close it out if the response is appropriate. It's important to note that we want all communications between the Quality Assurance Committee and the member clinics to occur through the QA portal. And this is important for several reasons. The main two are that it maintains privacy of the citation. This way the citation is protected behind your password for your clinic, and no other person or clinic can see that. The other thing is that it helps us maintain a record of all communications as we move forward in the future. We can't effectively do this by email, phone, mail, or fax, but if you reply within the QA portal, that communication is there forever, and we can go back and look at those communications as we need to in the future. These are the 5 primary metrics that the QA committee has established that you will see on your scorecard. The first is cumulative live birth in patients under the age of 38 years old. For the 2017 scorecard, the 5th percentile was set at 20%. So any clinic with a 20% or less live birth rate in these patients would receive a citation. The next is cumulative multiple rate in patients under the age of 38. The 5th percentile nationally in 2017 was 35%. So any clinic with a 35% multiple gestation rate would be cited. The multiple birth rate in donor oocyte cycles is set as the same for whatever the cumulative multiple rate is for patients less than 38, as we feel that both of these patient populations represent good prognosis patients. So this was also set at anything over 35%. The final 2 are the transfer of an excessive number of embryos in any single patient. So if the clinic has a transfer of 4 or more embryos in any patient under the age of 38, that would result in a citation, or any transfer of 5 or more embryos in a patient 38 to 40. It should be noted that these last 2 metrics that are bolded were reduced by 1 embryo each from 2017 to 2018 to reflect what we feel is safe practice in these patient populations. So once you receive a notification by email that you need to log into the SART QA portal, you go to sartcorsonline.com. You type in your username and password and the clinic to which you are assigned and click login. This takes you to your clinic's particular site, and at the bottom you will have various portals that you can access. You then click on the quality assurance portal. And then once you're in the quality assurance portal, you can click on the right to view your clinic's QA scorecard. The scorecard is too large to show effectively on one slide, but this is basically what it looks like, and we'll talk through each of these. So this is the scorecard for my clinic from 2017, and this is what it would look like when you log into your scorecard. At the very top, you would see if you were cited for any metrics that were outliers. In this case, there were none. This is looking at cumulative live birth as the first metric. It defines what that metric is so that you can understand it. It then gives you the national average, which in 2017 in this patient population was 40% with a standard deviation of 11. And then you can see your own clinic's values and understand that there was no citation given. And you can understand where your clinic performed given the national trends that we see in ART. This is the next one, which is cumulative multiple rate under the age of 38. For this year, it was 15% nationally with a standard deviation of 11, and you can see the clinic's value. Again, multiple percentage for donor is set at the same for multiples under the age of 38, which was 35%. This clinic did not do donor oocytes in 2017. The fourth one is the transfer of more than 5 embryos, which again is reduced to 4 or more embryos in 2018 in patients under 38. In this clinic, out of 352 transfers, there were none that were a violation. Again, it should be noted for these final 2, Doing this in any single patient would result in a citation. And the same data for patients in the 38 to 40 age group. So what do you do if one of these shows up in red and says that you have been cited for this and need to respond? You have your primary metrics tab, and over to the right will be a tab for communication, so you will click on that. And you see in the middle there where you can message and reply back to the QA committee after you have looked at your data and chosen how you will respond. You can then click the box at the top to send it to all the SART committee, or if you want to send it to just the SART committee member who sent you the citation, each of them are selectable down at the bottom individually. You can see that there's a box at the top for clinic admin. This is where we can select as a committee to send a message back to you that would go to the people who you have chosen to register in this portal to see this data for your practice. You would then hit post message. It would generate an email to the QA committee, so we would know to reply to you. So in summary, the SART QA committee upholds the ART outcome standards of SART membership. When you receive emails from the SART Quality Assurance Committee, log into the QA portal to view your scorecard. And if you receive a citation, it's important that you respond in a timely fashion to facilitate closure of that citation, which is our ultimate goal within the QA committee. That ends my presentation.
Thank you, Dr. Hell. I'll now introduce Dr. Duty. She completed her residency in obstetrics and gynecology at Baylor College of Medicine in Houston, and then subspecialty training in reproductive endocrinology and infertility at UT Southwestern Medical Center. She's board certified in obstetrics and gynecology and subspecialty board certified in reproductive endocrinology and infertility.
Thank you, Ethan. As Ethan mentioned, I'm one of the validation committee co-chairs. The other co-chair is Tex Wimia from Texas Fertility in Austin, and Stephanie Nichols-Burns from Yale is also a committee member. My focus today will include reviewing the goals of the validation committee. I'll discuss metrics used for identification of clinics for validation visits. Finally, I'll discuss our communication within our committee, other SART committees, and the membership through the use of the validation portal. The goal of the validation committee is quite straightforward. Simply put, the purpose of our committee is to ensure accuracy of data collection for all SART member IVF clinics. Validation of IVF data is important. Accurate data collection optimizes the patient's perception and understanding of treatment outcomes and success rates. Accurate data also allows the patient to make a more informed decision. The concept, intent to treat, speaks directly to the patient's viewpoint. Her question is, what is my chance for success from the point of cycle initiation? Finally, SART data is also used for clinical research, and so accurate data yields better research. Before we discuss the validation portal further, I'd like to recognize Steve Spandorfer and Barry Witt, my predecessors, the past chairs of the committee. They played an integral role in the development of the validation portal and used their years of experience with the paper trail to create the virtual world we are now utilizing. There are numerous metrics the committee utilizes to analyze data. This slide shows a pull-down window listing many of the current metrics. After data submission is complete in SART CORS, the validation committee then can generate a report of metrics for every clinic. This report will indicate whether or not a clinic is an outlier in any category. The metrics used each year can change depending on the current year's data and the review by the validation committee. A logical question would be, who is an outlier? And is every outlier clinic chosen for a validation visit? So commonly, 2 standard deviations is used to determine who is an outlier in scientific fields. That is appropriate when the data is normally distributed, but in a moment I'll share an example which demonstrates a different approach may be indicated for analysis if the data is non-normally distributed. This want to point out, is every outlier clinic chosen? So one example shown here is that a clinic might be chosen as an outlier. For example, this clinic reported a 25% live birth rate in women over the age of 42. This is understood, this is explained by the low numbers. So only 1 out of 4 conceived. So it's an outlier, yes, but you can see that this would not be a selection for an audit. Every outlier variable is reviewed by a committee member. This snapshot illustrates a scenario where the standard of using 2 standard deviations isn't appropriate. This is just a snip from one page of the 2018 data looking at prospective reporting. You can see the range is from 0 to 82.6%, and no one is an outlier. Put a different way, we probably wouldn't agree with the teacher if our child got an 82% on a test and was given the same grade as a student who received a 0. So prospective reporting is one that we need to look at in a different fashion. The range in 2018 was from 0 to 100%. The mean clinic rate was 66.4%, the median 81%, and 32 clinics had 0 prospective reporting. Additionally, 5 more had less than 1%. So prospective reporting is probably an area that we need to all work on improving. Just wanted to show how the validation portal looks from our perspective. And again, Micah did an excellent job walking you through how to log into the QA portal, and you would use the same steps for the validation portal. So we can pull down our key metric summary. We can choose one of those metrics and run through all the clinics and look to see outliers. So in summary, the use of the portal is for us to be able to communicate well within our own committee, talk between SART committees, and finally to communicate with our membership. Once we have gone through all of the clinic's data, we will issue a scorecard. If there's not a problem, everything looks very appropriate, then you'll receive an email to look at your scorecard. Again, that's private only to the clinic. It allows you to compare yourself, look at how you compare to the other clinics in the country by the averages. If we find that there is something that needs to be addressed, then you'll receive an email from the validation committee to log into your portal, and we will communicate with the question or citation that we have. We feel very strongly that privacy and ease of communication are vital. Our committee plans to only utilize the portal for any communication. From a committee standpoint, it does allow us to follow the trail of our communications, and different than QA validation, if a clinic is selected for a validation visit, it does require an in-person visit, usually to validators spending a day. So we want to be able to make sure that we've communicated well, that we have chosen a date and time that works for the clinic. So if you are asked to do a validation visit, the email you receive will ask you to list several date options for us to try to schedule that within a 30-day time period. So, and that concludes my presentation. Please feel free to email me at kathyd@embryo.net if you have any questions that I can answer for you. If there's anyone on the webinar who has an interest in validation, please reach out. We could certainly use more individuals for the validation process. Thank you.
Thank you, Dr. Duty. I'll now introduce Dr. Aly Reshef. He is a senior physician at the Integris Bennett Fertility Institute. He completed his residency at the University of Alabama at Birmingham and subspecialty fellowship training at the University of Louisville, Kentucky. He is double boarded in obstetrics and gynecology and reproductive endocrinology and infertility. Dr. Reshef is also clinical associate professor, Department of Obstetrics and Gynecology at the University of Oklahoma Health Sciences Center.
Thank you, Ethan. First of all, I'd like to acknowledge the incredible work of Ethan Wantman and his organization, his company, in helping SART creating the portal. The portal is a little bit daunting to those who are not familiar with it, but it's very much like you get a new car and they explain to you all the features in a new car, and you use probably 5% of those features. So obviously, for those that are daunted by the features, they don't have to know every bit of it, but clearly familiarity with how to log on, how to communicate with SART is very, very crucial. I'm the chair of the SART Advertising Committee. It has 11 members, including myself. All committee members are either board-certified REIs or PhD HCLDs from coast to coast, private practice, academia. We essentially review websites of SART clinics for advertising violations. And SART is very unique in a sense that advertising oversight by a medical organization does not exist anywhere else in the world. SART is unique in a sense that we look at advertising practices knowing fully well that the nature of what we do is extremely sensitive, and information must be given to the public in an accurate way, non-misleading way, and that's where we come into the picture. We review 1/3 of all SART clinics each year, meaning review their websites. We also address complaints of one SART program against another, and we use the SART advertising guidelines as a reference, and you can find the guidelines both on the SART.org website and also on the portal. I believe it's on the upper right side. Basically, the way we communicate with our membership is we enter complaints from our review of a website on the portal. If there are no violations, and again, the metric is our SART guidelines, so advertising guidelines, which we modify every once in a while. The last modification was in January of 2018. We're working on a new version that hopefully will be approved by the SART board in a month or so. If there are violations, we contact the medical director, either by phone. Ideally, we should contact by the portal, but the awareness of the existence of the portal is still not ideal by SART member clinics, and so eventually we'd like to do all the communications through the portal, but we make every effort to communicate by phone, by the portal, or through the SART mobile application with the medical director, who is ultimately responsible for the content of their advertising, especially the website. Once we tell the clinic, hey, you have violation, we give them 2 weeks to make the changes and make corrections. In this day and age, making corrections on a website should be fairly swift, and most people are very compliant very quickly. If the clinic doesn't respond in 30 days, we put a red flag on their clinic SART CSR, the clinic-specific data. And basically, when you look at the clinic results on the SART website, you'll see a red flag which will say something to the order of, this clinic is in violation of SART advertising guidelines. Please view their information with care, something to that effect. Obviously, that red flag is quite ominous for people and clearly affect their acceptance by their patient population and, in a way, their income. So people respond to the red flag, the very few times that we ever put it, very, very swiftly. If we don't hear from the clinic in 90 days, they don't correct their violations, we then remove their SART data from the SART website altogether. If 6 months go by without response, the executive committee of SART will talk about membership in SART, and the clinic may lose SART membership. While the actions that we take sound fairly draconian, believe it or not, and I'll mention that a little bit later, we have very few people who are non-compliant over 30 days. And most of our SART members respond to us very quickly within 2 weeks and make the appropriate changes. So the gist of the advertising guidelines, and you can read them on the SART website or on the portal, is that you should not present misleading information to your patients and to the public. You cannot misrepresent your clinic's success data, and that primarily involves the supplemental data. We require all clinics that present success data, and by the way, presentation of success data is not mandatory by SART. If you choose not to present your success rate, that is fine. But if you do, you must have a direct link to the SART CSR so the patient, the public, physicians can click on it and validate your data based on what you gave to SART. You should not denigrate other SART clinics. I think that's collegiality. And use unsupported statements like, we are the best in the Midwest, we are world known, etc. These are statements that are not supported, and we try to avoid those. You also should not compare your clinic statistics to other programs in your area. You can compare them to national statistics, but not to other clinics. So this quick example of the portal, and if you look at the bottom, you see advertising portal. This is my view. It may not necessarily be your view as a clinic, but if you look at the orange/yellow closed, that means that we reviewed the clinic. There are no violations, whether initially the clinic never had violations or they fixed them within 2 weeks. We send them a letter and saying, basically that states you have no advertising violations, and that case is closed. And this is my view as the chair of the advertising committee, and that just gives you the general view of which clinics we reviewed, which clinics we closed. It gives me an oversight of what my committee members have done, what cases we've done, what cases we closed, what are still open. And these are the criteria in the box of how we evaluate a clinic. If they have claims of superiority, the drop-down menu allows us, committee members, to tell them, hey, this is a claim of superiority. We can cut and paste the actual claim of superiority to say, hey, this is not permissible. We can put the URL or the link to their own website, etc. So these are the criteria by which we judge clinics' advertising violation. How effective are we? And again, we review only 1/3 of all SART clinics every year, and all 391 programs cannot be reviewed in 1 year. They're just too onerous for our volunteer committee members. We are blessed by having an organization like SART, which is a voluntary organization, but members value the membership in SART so much that their response to our inquiries are quite rapid, and they make corrections quite promptly. The majority of them make corrections within the required 2 weeks. I think part of it is because we try to be collegial. We are colleagues. We are reproductive endocrinologists. We run clinics like all of you, or some of us are PhDs that run labs, and we don't intend to be punitive, just like QA or any other committees. It's clearly important for a voluntary organization to act in a collegial way, and currently there are no red flags, which is what we put if clinic does not make changes after 30 days. So in the entire 391 programs, there are no red flags on any clinic. There are no clinics who had their data removed because they didn't respond in 90 days, and it's rare or almost unheard of that a clinic will lose its membership just because of advertising violations. Once again, SART is the only medical society with advertising oversight. It's unique. It appears to be oppressive on the surface, but the rate of response is an attestation that people, once again, value their membership in a voluntary organization like SART. And we very much appreciate how Ethan, Paul Lynn also deserves credit for creating the portal for advertising and working on the portal altogether, that hopefully SART members will adopt the portal as a way to communicate with us. And by the way, if there is a complaint by another clinic against another, we deal with it without the complainer and the complainee knowing who is who. So obviously confidentiality is extremely well preserved, and you can launch complaints against another clinic without the fear of repercussions. Thank you so much.
Thank you, Dr. Reshef. After those, great presentations on the SART portals and all the work that the committees do to help make sure that SART's quality, accuracy, and truth in advertising are supported, I'm just going to give a quick overview on how you get to those portals and how you can create users or edit user rights at your clinic to access each portal. Adding a user account or user access to the portal lets them see status changes to scorecards or reviews. It allows communications with committees that some of the presenters have talked about that are linked to a scorecard or a review in the advertising portal or an application in the case of the research portal. And it informs the users by email with alerts when something changes in the portal for a respective clinic, or if there's a communication, status change, that kind of thing. And like Dr. Reshef mentioned, there are portal buttons on the bottom. If you see, at the bottom, you can see a few buttons, and we have some more portals than were discussed today, but that's really where you get them. So if you log into SART CORS, and this is your homepage, and you don't see any of the buttons at the bottom, you'll want to talk to whoever at your clinic has administrative access to SART CORS. Those are the people that control user accounts at your clinic. and they can set you up with access to these portals. And so if you click user list on the previous screen, this is what you get. And if you don't have access to user list, that's fine. This is what the administrator will do to give you access to the portal. So this shows if you do have access to the user list, you can even edit your own account potentially. If you have a My Account button, you click that and you get this list. And then you'd click on an individual account, or you'd click New Account if you wanted to make a new account for the portal. And then you get the user account page where your existing account or your new account, you'd fill out all the information, and you'll see that line sort of across maybe 2/3 of the way down that says Portal Access. And you'll see those checkboxes make this user an admin for the portal at this clinic. And that means this user can then see those buttons on the homepage to access each portal, log in, check communications, they get alerted to things, that kind of thing. It's just that simple. And I think the first question is for Dr. Hill. How should I respond if I get a message in the portal?
Yeah, thank you for that question, Ethan. So if you get a message that you have a QA post in the portal and you log in there and there's a citation, what we want you to do is look at your data for that citation and see if you can explain it through changes or trends in your practice. A lot of times what we'll see is that a clinic will have a high twin rate, and it's because over time their laboratory conditions have improved, but they're still transferring to embryos. The other thing we'll see is that the QA data is always lagging by 2 years because it takes that long to collect it, wait to live birth, and validate it. And so sometimes your lab has improved over time. And so maybe your live birth rate was below 20% 2 years ago, but you've made changes and you're already seeing it come up. That's really all the information that we need. If that's what you're seeing, we just want you to look at the data, see if you can explain it, and reply. If you can do that, we'll be able to close out the citation, and we'll just look the following year to make sure that we're seeing those improvements.
Great, thank you, Dr. Hill. The next question is for Dr. Duty. What if I need to change data after it has been finalized? Is there a way to do that?
Yes, there is. So there are multiple reasons someone might need to re-enter their data. Could be due to a validation visit. Could also just be to an error that you realized you made. If you email Kelly Jefferson, there's an SOP for revising your data. Very simple and straightforward to do.
Thank you. And I think the last question is for Dr. Reshef. Can I complain in the advertising portal about another clinic's website?
Yes, you can, you should, and we address it promptly. Actually, I just had one yesterday. We take it very seriously. Your name, once again, if you're a complainer, will not be submitted, and we try to also limit the allusions. It was somebody in your town that complained about you, because obviously many times you can figure out who complained. I sometimes will not even say there's been a complaint against you. I will say I reviewed your website, I as the chair of the advertising committee, and the following is off, so you need to fix it. You can do it through the portal. You can do it by contacting me directly. I normally have a cell phone that is given to anybody at will. If you're having difficulty in reaching me, you can contact Kelly Jefferson. Kelly at SART will send me an email with your contact information, and I'll call you. And don't fear talking to me, by the way. And once again, I'd like to hear from you. So however way we can communicate with you, I'll get back to you, hear the complaint, and address it promptly.
Thank you. Well, I think that concludes. I think that's the last question I see.
Thank you to our panelists, to our moderator, and to the attendees. You will receive a survey by email after this session. Your feedback helps us give you the most relevant content. Your input is appreciated. This session was recorded and will be available on our website in the near future. Join us for our next webinar, scheduled for Tuesday, June 16th, on the ASRM ASHRAE IFFS statement on COVID-19. For any further questions or comments, please don't hesitate to contact us at webinars@asrm.org. This concludes the webinar.